Thank you. So I'd just, of course, like to thank both our moderators as well as the program committee. It's absolutely a privilege to be able to speak with you today. These are my disclosures, and my biggest disclosure is just a very warm thank you to both Brian Haugen and Yuri Nikiforov for sharing several of their slides with me. So what I was asked to discuss for you today is really rooted in that second case that was presented of the young man with the centimeter size suspicious for papillary thyroid carcinoma nodule. And of course in the setting of this strong family history of papillary thyroid cancer. So what is suspicion for papillary thyroid cancer? So I couldn't agree with Dr. Witt anymore. We like to employ the lexicon of cytology, which incorporates the Bethesda classification system. So this is a Bethesda 5 lesion that comes with an estimated risk of malignancy of between 60 and 75%. Now that's based on the initial publication by Ali and Sebas. The actual risk of malignancy in these suspicious for papillary thyroid cancer nodules that go on to surgical resection is about 70%. That's the median risk, with a range that extends fully from 53% to as high as 97% in some series. Well, what do the guidelines say? So we've tried to complement each other. Dr. Witt discussed the NCCN guidelines. The American Thyroid Association guidelines last published in 2009, but were recently in an immature state debuted at the Endocrine Society in Chicago. And what they say is that if the cytology is suspicious for papillary thyroid cancer, surgical management should be similar to that of malignant cytology, given that high risk of malignancy. But obviously, it does depend on clinical risk factors like the setting of a strong family history of papillary thyroid cancer, the sonographic features. We can never get away from using ultrasound as an important diagnostic tool. Patient preference. So obviously, all the alternative strategies you're hearing today come with a relative set of risks and benefits, which in the end must be resolved by the patient with our counsel. And then possibly the results of mutational testing. So this is a strong recommendation, but indeed with low quality evidence to date. So the ATA guidelines, which again are still under construction, go on to say that after consideration of clinical and sonographic features, mutational testing, not just for BRAF, but also other mutational markers such as RAS, RET-PTC, PAX-A, PPARgamma, etc., may be considered in nodules with suspicious cytology if we believe that data would be expected to alter surgical decision-making. And I think when we use that term, alter surgical decision-making, what we are talking about is the extent of surgery. Are we going to perform just a diagnostic procedure, that is a lobectomy, or are we going to do a diagnostic and therapeutic procedure, that is go directly to total thyroidectomy? And this is a weak recommendation with moderate quality evidence. Well, what would my recommendations be based on the unique case that Dr. Shindo presented? Well, I think when I see patients with potential family history of disease, I always have them see our genetics counselors. We always interrogate both the central and lateral compartments of the neck, looking for metastatic disease in order to be able to preoperatively better risk stratify our patients and do a definitive operation up front. We want to have an extensive discussion regarding risks and benefits of lobectomy versus total thyroidectomy, and quite frankly, even now, based on the ETO data for micropapillary thyroid cancers not necessarily seen in the setting of a familial history, careful surveillance and observation may be an acceptable strategy, but patient preference is always important. In the end, in this case, I probably would have recommended thyroidectomy. Well, what are the considerations? So again, the likelihood is high that this was a PTC and the family history was strong. We know the familial papillary thyroid cancer is more often associated with multifocal disease and extrathyroidal extension. It was seen in the setting of a young man. Gender plays a part. but at the same time, the tumor was small, and certainly Dr. Shindo described no high-risk features to the lesion. So probably in this setting, mutational testing would not have changed my recommendation for surgery or extent of surgery, but that is not always true in my practice, and indeed, I do employ mutational testing. So Dr. Witt talked about which patients really don't need surgery, and when you approach a patient with a low clinical or ultrasonographic suspicion for cancer, the gene expression classifier test is an appealing option because of its high sensitivity and high negative predictive value. But what I want to focus on are those patients who you're thinking about sending for surgery, and you're trying to decide as surgeons how much surgery should you do. In that setting, mutational panel testing is the more appealing option in that it has high specificity and positive predictive value. Until recently, it has been limited by relatively low sensitivity, if you cull the literature, somewhere between 48 and 63%. In other words, mutational panel testing cannot always reliably rule out cancer with a negative test. Well, we've made a lot of progress over the last 15 years in identifying mutational markers for thyroid cancer. In 1990, just 20% of the pie was understood. By 2000, that had increased to 30%. By 2005, a giant leap forward to 70%. And in 2014, we probably now understand more than 90% of the mutational markers that are associated with papillary thyroid cancer. So Galectin III was one of the first markers identified. This requires obtaining cell blocks to perform stains. The initial data were published by Bartolazzi in 2001. And in a set of histologic specimens of those that were benign on final surgical pathology, just 5% were Galectin III positive, but among the malignant histologies, fully 100% were Galectin III positive, affording the test a specificity of 90% and a positive predictive value of 81%. He then extended his examination of Galectin III, looking at 432 nodules across multiple centers in a prospective blinded trial. And I always like to show what the malignancy rate that was associated with indeterminate cytology. So this had a 30% malignancy rate. And in this large series, Galectin III had a specificity now up to 93% with a positive predictive value of 82%. Well, we saw an overview at the very beginning of the panel where we've talked about some of the thyroid tumor signaling that we all have to understand. So RET PTCs account for about 15% of papillary thyroid cancers. BRAF, somewhere between 40 and 60% have a BRAF mutation. RAS sort of sits on the fence, crossing into both the papillary and follicular thyroid cancer worlds, representing between 10 to 15% of both kinds of cancers. And then PAX-A, PPARgamma resides in the arena of follicular thyroid cancer at 20 to 40%. So back to the question, which patients with indeterminate cytology should I send for surgery, and what is the extent of the surgery? So you've heard Dr. Witt discuss BRAF V600E. This mutation is highly specific at 100%. If you actually cull the literature, there are some that were faulty, so we say 97 to 100%. With a positive predictive value of nearly 100%. Well, which patients with indeterminate cytology can avoid surgery using BRAF V600E? And this is the weakness of the BRAF V600E test. It has a very low sensitivity and low negative predictive value. So it is used to identify cancers, not to exclude benign lesions. Well, then we became more sophisticated. So in 2009, a prospective blinded molecular analysis study of 328 patients who had 470 nodules was performed in conjunction by the Universities of Cincinnati and Colorado. They looked at RET PTC1, PTC3, RAS, BRAF, and PAX-A, PPARgamma. And there were 52 indeterminate cytologies among the 470 nodules. In the end, there was a 40% malignancy rate. And using these 5 markers, they achieved a specificity of 100% and a positive predictive value of 100%, but again, with much lower sensitivity and negative predictive values. Then in the University of Siena, they added one more marker to their analysis of 235 nodules. And note, the malignancy rate in this series was significantly higher than the prior series, and that is one of the difficulties in evaluating data across studies, is the unique malignancy rate associated with indeterminate cytologies very much differs from series and indeed from institution to institution. Using these 5 markers, you now have a specificity of 98% with a positive predictive value of 98%. So we're getting better and better. So this is a study published by Dr. Nikiforov in 2011, and this was a very expansive study, 479 patients with 513 indeterminate biopsies, of which 247 were AUS plus, 214 were follicular neoplasms, and 52 were suspicious for papillary thyroid cancer. And here you see that with his testing, they achieved a positive predictive value of 89% and a specificity of 98%. But now you see we are starting to enhance, he's enhancing the sensitivity and negative predictive value of the test. That is the Achilles heel until then of these mutational panels. Well, there's a genomic revolution going on right now, and that revolution is next generation sequencing. Currently, we've been living in the world of conventional sequencing using chain termination reactions. We sequence anywhere from 10 to the 2 to 10 to the 3 bases with a sensitivity of just 20 to 30%. And the cost can be quite high. And you're, of course, only able to interrogate one region of the genome. Next generation sequencing is a whole a different thing in that you are able to massively parallel sequence clonally amplified DNA templates on the order of 10 to the 6 to 10 to the 9 bases, and now the sensitivity drops significantly to 3 to 5%, as does the cost. And perhaps most importantly, you're able to rapidly interrogate multiple regions of the genome, indeed up to the whole genome. And this gives us much greater power to ask bigger questions. So that is the expansion of mutational panel testing from when it was just at approximately 70%. When we added several of the mutations I showed you, we then got up to 81%. And that was the debut of ThyroSeq 2.1, which was published in 2001 by the UPNC team. And here they used targeted next-generation sequence paneling for detecting mutations in thyroid cancer, and now have a specificity of 95%. And you see now the sensitivity has increased all the way up to an equivalent value of 95%. So this is extremely promising. And what is left? Well, there's about 9% left of novel rearrangements and novel mutations that have yet to be fully understood, but of course, they also now are the subject of study. And ThyroSeq version 2 is a 60-gene panel, more than 60 genes actually, more than 400 hotspots and unique fusion points, 14 genes for point mutations, and 48 gene fusions. And I would say sort of the sky is the limit, and I know prospective testing is about to begin across the United States. Well, it's important to understand that there are multiple kinds of molecular testing, and this is a study that was just published this year, 2014, using an alternative approach to that shown from UPMC, using RT-PCR and liquid bead array flow cytometry. And you see in this study, in nodules that had both indeterminate cytology as well as mutational testing, specificity was 89% with a positive predictive value of 88%, so slightly lower. Well, what are the limitations? Are there limitations to all of this? And I think it is important to understand the strengths of new technologies and new techniques, but also understand the limitations, because this has to be included in the way you counsel patients. First of all, there are no long-term follow-up data available. I think follow-up is actively underway, but currently it is very short. So we don't necessarily know long-term what is going to happen to these nodules that have been deemed to be benign. If emerging evidence and guidelines begin to suggest that lobectomy and near total and total thyroidectomy might both be acceptable alternatives for low-risk differentiated thyroid cancer, then one question I might raise is the role of mutational panels for determining extent of surgery limited? That is, if it's okay to do a lobectomy for a low-risk DTC that is, say, 2 centimeters, in an indeterminate cytology, what would be the benefit of rule-in testing? So I think that's another terrain that's become a little rocky. And then finally, another limitation is knowing your own data. And I would challenge everyone in this room to know what the histologic, cytologic correlation is in the setting of indeterminate cytology at your institution, because when you know that, you can better choose whether to use, say, the gene expression classifier or mutational testing. So know your data. And in the end, I suspect that molecular markers will continue to take on a greater role in our thyroid diagnostics, hopefully eliminating the 30% of nodules deemed to be indeterminate, pushing them either towards a positive or benign result. Thank you very much for your time.